Now we'll continue. Let's talk about impaired change in support strategies. So effective neural pathology on organization and timing of automatic stepping or reach out for support strategies to recover from an unexpected perturbation. So they studied a whole bunch of patients with Parkinson's, a whole bunch of patients with cerebral palsy. And so they found that, hey, what is the reason that these Parkinson's patients are falling or after they begin, you know, accidentally bumped into? Well, they found that patients with Parkinson's disease, they lacked anticipatory lateral weight shift. They had a delayed onset of recovery. They had to take multiple steps to recover. And sometimes they used a crossover strategy and they tripped over their own feet. Okay, so those were the reasons that they found it. So when these Parkinson's patients were put to the test, okay, and then so these are the things that they found. So then from a rehab standpoint, we need to say, okay, well, they lacked anticipatory lateral weight shift. So we need to work on lateral weight shift. It says it took multiple steps to recover. So we need to teach them about base of support. And then we need to teach them about crossover strategies and say, hell, don't do that. You're going to fall. Okay, so don't cross your legs. Okay, so those are some things that you say, okay, now I can teach them stuff versus just saying, okay, let's just do the normal leg press and bicycle and just do some sit to stands. Well, that's not going to help a patient that has using a crossover strategy though, to recover. Okay, so this is why it's important to have very specific exercises for your patient clientele. All right. Again, we also want to do their assessment in sitting. So reactive balance in sitting, optimizing trunk support enables emergence of reactive balance control in the head and the trunk. Clinical implications, assessment of reactive balance, treatment programs to improve recovery strategies. So we can definitely start with the reactive balance in sitting. So you're thinking, okay, they have some issues with balance in standing. Well, before I start there, let's go take it back a notch and let's work on sitting and see if they can even recover in sitting and then go to standing. So it's okay to go back. Take 2 steps back to go 1 foot forward. Well, sometimes that's what it takes with a neurological patient. What they found in kids with cerebral palsy used a top-down recruitment versus a bottom-up. So high co-activation of antagonists. So when you're working with kids, really what they want you to do, or when we think of balance, we go, okay, well, ankles, knees, hips, then trunk. But unfortunately, kids with cerebral palsy, they'll start trying to recruit muscle patterns from the top down. They might start recruiting shoulders, arms, then their trunk, then their hips. By that time, that's already too late. So that's the poor sequencing of cerebral palsy kids, Malachi and Thomas. And they also had a high activation, co-activation of antagonists. Remember I told you if you're trying to lift a book and your tricep and your biceps are contracting at the same time, you're not going to get very far. Okay, so remember the biceps has to overpower the triceps in order for that book to get closer to you. So now we go into anticipatory. Now when we talk about anticipatory postural control, one of the things you have to realize is anticipatory postural control is based on our past experiences, right? So we have to have the ability to remember past experiences in order for us to improve anticipatory postural control, meaning, oh, I remember last week I was lifting that box of cat litter, and now I'm going to anticipate it weighing the same 20-25 pounds. So it's based on past. So if patients have neurological issues where they have issues with long-term memory and they can't remember anything, well, then their anticipatory postural control is going to be crappy because they can't remember from past experiences. So if you have someone that has poor short-term memory, poor long-term memory, well, then anticipatory control is going to be very difficult to treat. So loss of anticipatory processes that activate postural adjustments in advance of potentially destabilizing voluntary movements, anticipatory postural activity dependent on previous experience and learning. So we want to start off with anticipatory balance in sitting. External trunk support can reduce effect in impaired anticipatory postural adjustments in the trunk. Best support is under the axilla. So for Malachi and Thomas, you would want to have support under the axilla. Some of the clinical implications that you could have is activities that stabilize the center of mass prior to voluntary movement, and treatment strategies that improve anticipatory postural control, improve functional skills. So you have to work on anticipatory postural control before you start reaching and having them tie their shoes or working on anything functional, because they have to anticipate that. So the bottom line is we need to have steady state, we need to have reactive, and most importantly, we need to have anticipatory balance in order to safely perform ADLs and prevent falls. So anticipatory posture control is probably the most critical component of the efficient and safe performance of many activities of daily living. Activities such as reaching, lifting, objects that are potentially destabilizing, meaning a heavy grocery bag can throw you off balance, opening a heavy door, or stepping up onto a curb all require activation, anticipation of those postural muscles which stabilize the center of mass prior to voluntary movement. So it all comes back to, okay, can we stabilize ourselves prior to that? And you and I take it for granted, right? We don't realize all of the stuff that has to go into before to prevent us from falling. But someone with a neurological deficit, unfortunately, all this stuff has to come to light, and they have to be more consciously aware of it so that they don't fall. So now as we move on, we have to look at sensory and our perceptual system. So normal postural control requires the organization of sensory information from our vision, somatosensory, and vestibular systems. So 3 systems. And really that information of where the body is in space and the movement with respect to the environment and coordination all play a role. So for a child with cerebral palsy, he has to use his vision, inner ear, vestibular, and somatosensory in order to maintain that. If he has difficulty with somatosensory, then his vision and vestibular system have to work twice as hard in order for him to compensate. So, sensory problems affecting steady state normal postural control requires all 3 systems, which is visual, somatosensory, and vestibular systems, to work together. If they disrupt the ability to adapt sensory inputs to changes in task and environmental demands and disrupt development of accurate internal models and perceptions of the body, then we'll have a very difficult time with steady state balance. Now, what ADLs would be tough for patient 5 and 6? So look at this. They have vestibular loss of subjects. Look at their sway index. Oof. Okay, so this patient, it's not too bad. Normal subjects. Okay, normal subjects here. Normal subjects. Normal subjects. But if they lose their vestibular, which is the ability, their balance, check out their sway when they're on something that's uneven surface. Okay, so if you look at how to interpret this, and it seems like a lot of information, but not so much. So normal is the white. There's 6 different tests that they're doing. So this is just eyes open, ears open, normal, flat ground. Eyes closed, ears, of course, here, and flat surface here. Their eyes are open, but they're in this dome, kind of a claustrophobic thing here, and they're still on even surface. Now they're on uneven surface. Okay, so it's interesting. Look at this. A normal person had a little bit more sway on a normal thing, but on uneven surface, they had less sway, which is not sure from that. But if you look at this, it's amazing to see that as soon as you take the vision and the somatosensory, the sway index just goes through the roof. So this is where you have to be careful with somatosensory and vision. So those are some exercises that we would definitely work with somebody that has vestibular losses. So we need to work on this kind of exercise, not so much these, but this kind of exercise to get their vestibular system better. Now, if they've lost somatosensory, which is the ability to touch and feel, well, on normal, they're okay. When their eyes are closed, they're not too bad. when it's still even ground, and that's not too bad. Funny thing is, somebody that has a somatosensory loss actually has less sway than a normal person, and with that, it's very interesting. So, you know, for these guys that have somatosensory loss, then we wouldn't really need to work on too much. So what does this tell you, right? So it tells you a lot of information. So if we look at this, what we get out of this is results show that instability in persons with loss of vestibular function occurs only in conditions in which vision and somatosensory inputs are not available for postural control. Okay, but if we have this one here, loss of somatosensory inputs below the pressure cuffs did not really affect the ability of these neurologically intact persons to maintain balance because the availability of the other senses to compensate and make up, and therefore changing demands and therefore not really affecting them. Okay, so they were able to still use their ears and their eyes. Here they were still able to use their vestibular system and it was fine. Okay, so the true indicator of poor balance, if you were to really interpret this, is someone that has vestibular issues. If it's anyone with a vestibular issue, and unfortunately vestibular issues are naturally occurring as we get older, but someone that is getting older and has vestibular issues from a neurological condition, it's like a double whammy, unfortunately. Okay. Now, classification scheme for identifying different problems related to organizing sensory information for stance, postural control. So here's normal adults and children. They're normal sway, normal children. When you take out their field, they usually have some abnormal sway. So children in general from 1 to 7, these are normal children. Okay, they're going to have some issues with somatosensory and vision loss anyway. So then you get a child that's between 1 and 7 with cerebral palsy or Down syndrome, they're going to have issues with that as well. Okay, now if they're abnormal, if they're visually dependent, they're going to be okay until you take out the field of vision. Okay, if they're surface dependent, meaning they can walk on flat, even grounds but not on uneven, well, they're going to be fine until you take off the somatosensory. If they have vestibular loss, again, we showed that from here, really you don't have any issues. And even if they're walking on uneven surfaces, it's when they're walking on uneven surfaces and you take their field off. When they have sensory selection problems, they're normal, and sometimes they'll have abnormal sways because of lack of sensations here and their ability to adapt to the changing environment. Okay, but based on this study, someone with a somatosensory loss is not as critical as somebody that has a vestibular loss. All right. Now, sensory problems affecting steady state. Availability of other senses to detect position of the body in space. Availability of accurate orientation cues in environment. And ability to correct, interpret, and select sensory information for orientation. So again, if your vision is hindered and you have the ability to work on your somatosensory or vestibular system, then that's a great thing. So after a CVA, patients rely heavily on vision, but as they improve, they rely on it less. So in the first few weeks of after a stroke, they rely heavily on vision. So if that tells you, if they're relying heavily on vision, then you need to educate them to say, hey, be careful in dimly lit places. Be careful in movie theaters. Be careful because that's what they're using for balance right now. But as they get further along, then they start using their somatosensory, then they'll start using their vestibular, then they not as prone to accidents, okay, because they don't rely on their vision as much. Now, just to refresh your memory, and this is something that, well, we have to have tests, right? And this is why I was wanted you to do this on a loved one. We would have done this in class, but we didn't get a chance. But I wanted you to show you how important the Berg Balance scale is in assessing some of these clinical measures of balance. The Dynamic Gait Index, the DGI, is also a great one, so I'll show you both of those. Activity-Specific Balance Confidence Scale, that's another one. So there's a lot of good ones out there. Again, I'll refresh your memory with the Berg Balance Scale. Then I'll show you the Dynamic Gait Index and show you some other tests. So again, in order for us to test reactive balance, anticipatory balance, steady state balance, we have to have tests and measures. We have to have something that we tested day 1, then 4 weeks into it, 8 weeks into it, 12 weeks into it to show that we're making some kind of progress. So that we saw those tests. Now, sensory problems affecting reactive balance, somatosensory inputs from lower extremities role in reactive balance. So triggering centrally organized postural synergies, providing direct sensory feedback. Now, so what we want to look at is how does the lower extremities play a role in your reactive balance and especially somatosensory inputs. So loss of somatosensory inputs results in profound changes in motor adaptation, earlier activation of anticipatory postural adjustments as a compensatory strategy. So instead of using the right muscles, you may recruit the wrong ones earlier on. So that's a key there. Now, let's look at so to put this kind of in perspective and kind of shed some light on this, you're thinking, okay, well, give me an example, Patel. Okay, yeah. So they did a study on diabetic patients, right? So you know that we all know that patients that have diabetes, they obviously have delayed or decreased sensation. So they will obviously have decreased somatosensory inputs. So even though the patients with neuropathy or diabetic neuropathy in the study showed that they had the same distal to proximal muscle activation right? So they recruited them the same. The onset of the muscle responses was almost delayed by 20 to 30 milliseconds in all the muscles. So the recruitment pattern was the same, but there was a delay in there. And that delay could be the difference between them falling flat on their face or their back because they weren't able to recover fast enough. So, and with neurological patients, they may recruit the same, but if they have that delay, then unfortunately, and from a rehab standpoint, sometimes there is not much we can do about the delay. We can just educate them to say maybe go a little bit slower and not rush through things. So those are some things that you want to consider. There are some things that are out of our control. We can't change, but we can educate the patient and say, okay, well, this is something that you may encounter. How do we fix it? Okay, so, all right.